All right, let's get right into it. Today we're talking about a diagnosis that, honestly, every single one of us in psychiatry has to have burned into our brains: Wilson's disease. And look, this isn't just some obscure, interesting fact for rounds. This is a big deal. Why? Because it's one of those rare conditions we see that's actually treatable, curable even, if we catch it early enough. So yeah, let's dive in. And this quote right here, it just hits the nail on the head. The stakes are incredibly high. The reason Wilson's disease is so critical for us, specifically, is that it often shows up first with purely psychiatric symptoms. That means we're on the front lines. We're often the very first doctors these patients see, which gives us this incredible, unique chance to stop irreversible brain damage and, I'm not exaggerating, literally save a life. So for this explainer, we're basically going to become clinical detectives. First, we'll get into why they call it the great imitator. Then we'll look at all its psychiatric disguises, hunt for the physical clues that give the game away, nail down the diagnosis, go over the treatment, and wrap it all up with some clinical pearls you can use in clinic tomorrow. So what exactly is Wilson's disease? You might hear it called hepatolenticular degeneration. Basically, it's this rare genetic disorder where the body just can't get rid of copper like it's supposed to. But here's the kicker for us. Psychiatric and behavioral issues can be the first and only signs for months, sometimes even years, before anything else pops up. Now, you might see that number, 1 in 30,000, and think, okay, that's pretty rare. And it is. But the consequences of missing it are so devastating that it becomes a can't-miss diagnosis. It's an autosomal recessive disorder. All that means is you need to get a bad copy of the gene from both mom and dad. The gene in question is called ATP7B, and its whole job is to kick extra copper out of the liver. When it's broken, the copper just builds up. And this is a great way to visualize how that works. If both parents are carriers of that faulty gene, well, for every child they have, there's a 1 in 4 chance that child will have Wilson's disease. There's a 50% chance they'll be a carrier, just like their parents, and a 25% chance they'll be totally in the clear. And this is exactly why, if you diagnose someone, screening their siblings and children is an absolute must. Okay, now we're getting to the part that's most important for our day-to-day practice. Psychiatric symptoms aren't just some small side note in Wilson's disease. They happen in most patients, and they're very, very often the reason the person comes to see a doctor in the first place. This disease is a master of disguise, you know? It can look like almost any other primary psychiatric illness. So, depression. That's the most common way this thing shows up psychiatrically. But you're probably thinking, we see depression all day, every day. How on earth do we tell this apart? Well, here's the clue. The depression might be accompanied by some weird cognitive stuff. You know, maybe the patient seems a little clumsy or has a tiny tremor they can't explain. And the biggest red flag? It just doesn't get better with our usual SSRIs. When you see that whole picture together, that's when the alarm bells should really start ringing. And I mean, just look at this list. It really drives home how sneaky this disease can be. You can have mood disorders that look exactly like bipolar disorder, psychotic symptoms that make you write schizophrenia in the chart, big personality shifts like sudden irritability or disinhibition. Throw in cognitive problems and even catatonia, and you can see how easy it would be to misdiagnose someone for years. So if the psychiatric symptoms are such a perfect costume, how do we unmask this thing? The secret is in the physical exam. The clues that can blow the case wide open are often right there if you look carefully at the patient's eyes, their hands, and just think about their liver. And the absolute first place you gotta look for a clue is the patient's eyes. This is one of the most classic signs in all of medicine, and it's something we can actively check for. We are hunting for Kayser Fleischer rings. They're these golden brownish rings made of copper that get deposited right on the edge of the cornea. Now, you might not be able to see them with the naked eye, so here's the key takeaway. If you have even a tiny suspicion, you need to get an urgent ophthalmology consult for a slit lamp exam. That's the only way to really see them. Okay, from the eyes, let's move on to the hands. A really careful neurological exam, especially focusing on the arms, can give us another huge telltale sign of Wilson's. The classic finding here is what we call a wing-beating tremor. The way you check for it is you have the patient hold their arms out, bent at the elbows, kind of like they're trying to stop traffic. With Wilson's, you might see this weird, jerky, flapping motion. It's a really powerful clue, especially when you see it with other things like dysarthria, that's slurred speech, or dystonia, where muscles contract and cause these strange postures. And beyond the eyes and hands, there's more to look for. On the liver side of things, any young person with weirdly high liver enzymes, an enlarged liver, or a history of hepatitis should make you suspicious. And neurologically, you gotta pay attention to how they talk, any weird postures, a shuffling walk,
or even a masked or expressionless face.
Okay, so let's say you've got a high index of suspicion. The psychiatric picture is weird, and you found a few of these subtle physical clues. What's next? Now we have to move from just being suspicious to being certain, and that means a systematic diagnostic workup. And this is the path you want to follow. It all starts with you, with your clinical suspicion. From there, it's on to some initial blood and urine tests, that slit lamp exam we talked about, and maybe even a brain MRI, which can show some really characteristic changes in the basal ganglia. But the final, definitive step is often going to be a liver biopsy. So let's just break down what we'd expect to see. Typically, you're looking for a low level of serum ceruloplasmin. That's the protein that carries copper around in the blood. At the same time, you'll see sky-high levels of copper being dumped into the urine over a 24-hour period. But while all these tests help build your case, the gold standard, the thing that really confirms it, is the liver biopsy. It'll show a massive amount of copper built up in the liver tissue itself. So once that diagnosis is confirmed, everything shifts to treatment. And honestly, this is the really hopeful part of the whole story. Wilson's requires lifelong treatment, for sure, but if patients stick with it, they can live totally normal, healthy lives. The plan is usually broken down into two main phases, and this timeline lays it out perfectly. Phase 1 is all about getting that toxic, excess copper out of the body. We call it decoppering. We use meds called chelators like trimethoprim or penicillamine to do that. Then, once the copper levels are back under control, the patient moves into phase 2, maintenance for life. This is usually with zinc, which is pretty clever. It actually works by stopping the body from absorbing copper from food in the first place. So where do we fit into all this? Well, first off, this is a team sport. You absolutely have to be talking with hepatology and neurology. When it comes to our meds, SSRIs are usually fine for depression and anxiety, but you have to be super careful with antipsychotics because of the potential strain on the liver. Always, always monitor LFTs. And here's the really cool part. For a lot of patients, as you get the copper under control, their psychiatric symptoms just melt away, or at least get a whole lot better. Whew, we have covered a ton of ground. So let's boil this all down to the absolute essentials. The high-yield pearls that you can take with you and use in your clinic literally tomorrow. So, right before you walk into that room to see your next new patient, what are the key things from this whole explainer that you have to remember? What's going to help you spot this great imitator? Okay, here's the rundown. Number 1, any patient, and I mean any patient under 40 who walks in with a brand new psychiatric illness, you've got to have Wilson's on your differential, period. 2, got someone with depression or psychosis that just isn't responding to treatment? Think Wilson's. 3, always, always, always do a quick neuroscreen. Check for that tremor, listen to how they talk. It takes seconds. 4, ask about family history of weird liver or neuro problems. You'd be surprised what you find. And last but not least, if you've got a patient who's already diagnosed and their psych symptoms are getting worse out of nowhere, your first thought should be, are they taking their meds? It's almost always non-adherence. Look, if you remember only one single thing from our time together, let it be this. Always, always consider Wilson's disease in your differential for any young person who presents with a new psychiatric illness. Your suspicion could be the one thing that saves their brain and their life. That's all for now. Thanks for joining me.